Hello, this is Matt Link, President of NuVasive. This is truly an unprecedented time for us in healthcare, and certainly for each of you. And we really appreciate the opportunity to have a forum to discuss topics of interest to this audience, whether it be spine care or, in this instance, the global crisis we're all facing. Joining me today is Dr. Greg Mundis, who's facing COVID-19 in a really head-on manner with both his father and mother's recent positive diagnosis. And he has graciously allowed us to share his story with you and have a bit of a conversation with us today. Greg, thanks very much for joining us. We really appreciate your time. I know you have a lot going on, being on the road to support your family. Before we get started, you're an orthopedic spine surgeon in San Diego, but maybe for the broader audience, can you share a little about your specific background in your practice?
Sure. Greg Mundis here. I'm an orthopedic spine surgeon practicing at the Scripps Clinic in San Diego, and predominantly focus my practice on complex reconstruction, scoliosis, kyphosis correction, so mainly deformity work.
Thanks, Greg. We had a chance to catch up and we're chatting right before we kick things off, and what an unbelievable time we're living in and through right now. It's truly really no other word than unprecedented. We've known each other for quite some time, and we speak frequently, often about your practice, spine technology, innovation, and even our families. A lot of our discussions are focused on outcomes in spine. But today we're really speaking about something a bit different, maybe outside the lines, if you will, of what we normally discuss. We're facing this global pandemic with COVID-19, and you're in a position where you have a very unique perspective, as both your parents have been diagnosed with COVID-19. They're based in Springfield, Missouri, and you're there working with your family to help care for your parents. Would you mind just giving us some background on their story? When did they start showing symptoms? What were the symptoms? How did they get tested? As we know, testing is a scarcity in the United States, and really a topic that is of considerable conversation. And most importantly, Greg, how are they doing right now?
Thanks for inquiring, man. It's been, I think, a roller coaster for us all professionally, and then I guess for me personally, it's just been a bit of a different kind of roller coaster, as I've been having to deal with my folks having come down with this. My dad has a job where he gets to travel a lot and gets to host a lot of international folks. And about 2.5 weeks ago, he hosted some French delegates here in Missouri, and they had some speaking engagements, meetings, a dinner. The French delegate went home and started exhibiting some symptoms at the later half of that week, and were diagnosed that Sunday with COVID. If you back up 3 days from there, on Thursday, my dad started having just feeling kind of gross and spiking a low-grade fever. The next day had higher fevers and called me, and I said, get into testing right away. But they only tested him for the regular flu stuff. They wouldn't do the COVID on him because he didn't have shortness of breath or a cough. He just had the fevers. And so, unfortunately, his diagnosis got delayed by about 5 days because of that. So on the ensuing Monday, my mom called me and said, hey, he's not normal. This is 10 days ago now. He got tested that day. By the time he got home from getting tested through one of these drive-through test zones, he could hardly make a decision, could hardly walk. EMS was called. He was at the hospital around noon or 1, and then was on a ventilator by 5 o'clock that evening. So he had a pretty profound turn for the worse. And here we are 10 days later, remains on the ventilator. He's on dialysis because his kidneys shut down, and he's critically ill. So we're still unsure if he's going to make it. When we got the call on Monday, the call was basically, your dad's going to die. You should make your way out here. Fortunately, he's a pretty healthy guy, and he made it through the night, and has sort of been beating the odds ever since. So we're all rooting for him. Interestingly as well, just to give you context on the other side, is that my mom developed fevers on the Wednesday following my dad's admission. She went to the ER that night. I talked to the ER doctor, and he graciously, upon recommendation from me, put her on the hydroxychloroquine. She's allergic to azithromycin, so she couldn't go on the Z-Pak. And then she's been treated with that ever since. She has a couple more days left. But she ended up going to the hospital on Friday, was there through Monday, and then went home Monday and has been home since, and is kind of having the usual prolonged recovery from this stupid virus. So she's still kind of ups and downs with some fevers, but overall, thank God she's home and doing better.
Thanks for sharing that, Greg. First and foremost, great to hear mom is recovering and doing better given the circumstances. Obviously, we'll continue to keep your family, in particular your father, in our thoughts and prayers. You touched on a couple things that are of great interest, I think, for a lot of people, the limitations and the ability to respond effectively to this crisis and to this global pandemic. You mentioned the testing your father received. I guess if you can, provide a little more context, maybe a little more color of what you're observing as a provider. I mean, you're well informed in general around the environment. We're hearing a lot about the limitations, not just in the limitation of test kits, but with critical equipment, PPE, all of which is a factor in how the health system and the healthcare providers can effectively respond to this crisis.
Yeah, so I think that's a great point. I think, first of all, again, there was this social arrogance that we have here in the U.S. that kind of says, they got it, we're not going to get it. And the problem is that we're all getting it now. And so it leaves us in a place of not being adequately prepared. And that's what we're seeing right now. We kind of just felt like we were protected from it. The problem is that we're not. And then now we're having to react, unfortunately, in a way that's not ideal. Probably one of the greatest concerns to me, at least, is that testing availability is not there for everyone. And I'll give you a little, maybe a soundbite on this later as it relates to healthcare workers and then specifically for surgeons. That this is a huge concern. If you look at data on total tests per million people, United Arab Emirates had 12,000 plus tests per million people that they were doing. Okay, the United States, we're at 300. So this is a factor of 400 more tests being done in other places. And what happens is when you have more testing, you have more availability of understanding who has the disease, how you can quarantine them, how you can trace their contacts to make sure that other people aren't having more and more contacts. And so the problem is that we're not engaging in testing as well. And so this is a problem that could have been solved, but now we're sort of in the middle of it. So looking forward, we just have to have mass production. And fortunately, there are some centers like the Cleveland Clinic that seems to have now have like a 4-hour test. And there's some word on the street that there's other places that have a 1-hour test. Once we can get to a place where we can at least find out quickly if someone has it or not, we'll be in a lot better shape.
Yeah, so I think it's a great perspective, and it maybe brings the next question of you obviously were a practicing provider in San Diego, and there were exposures in San Diego, and my understanding is actually some exposure within your own health system, and now you're there in Springfield, Missouri. One of the things that we're hearing is that things are playing out on a regional basis around the globe and in the United States in a very different manner. What have been some of the observations you've had around how this is unfolding in your hometown of San Diego versus now where you are in Springfield, Missouri?
So 3 weeks ago today, we caught wind of this going to be happening, and before Scripps came out with their official recommendations, I actually canceled everything for the following week. I had like 3 deformities on among a couple other degen cases, and I had 2 busy clinics. I canceled everything because I felt like I saw the writing on the wall. And as a deformity surgeon, there is no reason why I need to electively put older people in the hospital that are going to be on a ventilator. It's socially responsible, and exposing them when our hospital had been exposed to me seemed very, it would be engaging in inappropriate use of my services. So the following Monday, which is when the news came out from Scripps that all elective surgeries were going to be put on pause for the foreseeable future, and it looks like now that this is holding true through the first 2 weeks in April as well. So what I'd like to do is give a shout out to Scripps for being ahead of the curve on this, being very aggressive in doing our part to make sure that we're not engaging in spreading of this virus. So that takes me to my perspective here in Missouri. So by the time I got here, we were already about a week into this process back home, and they had just gotten wind of it here in Missouri, because my dad was the first one in the ICU at this particular hospital where I'm at, which is actually a decently sized hospital, by the way. They were still letting all the visitors in. They were screening folks and testing their temperature when I got there, but they still allowed me to even sit at my father's bedside for 2 or 3 days. I think primarily because I thought he was going to die, and they wanted me to be around for it, I guess. But thankfully, that didn't happen. The lag though has been about 10 days here, and I guess my point again is that we really should be in a place where where that system is not being engaged in that kind of a delay. I'd much rather us see being aggressive all at the same time, because the real miracle cure for this virus is pretty simple. It's stay at home. That's the only message. If we limit its ability to spread, it dies. It dies out. It's just the way it is.
So as you look at where you're at today, Greg, and obviously, your primary focus is obviously on the health and wellness of your parents, and I know the safety of your family. A lot of the conversation has been around what a return, to quote unquote normal looks like. So as you think about your experiences today and over the last week to 10 days, how is that influencing your thinking moving forward within your own practice as a spine surgeon back in San Diego?
So that's a great question. I did a podcast for Mike Wang the other day for about 1,000 neurosurgeons, and I think my messaging was pretty aggressive, and it's the following. A lot of docs are concerned that we're going to lose productivity, we're going to lose in our income, it's going to be hard to recuperate. My rebuttal to that is the following. If we don't practice social responsibility, then this disease could keep us out of work for 3 or 4 months, much like it did China, right? The first case was on December 1st, and they didn't slow down. Their last, the first consecutive days of not reporting a COVID case was like late March, like middle to late March, right? So if we learn from that, if we just stop for a while, like this thing will fizzle out and die. And I'd much rather have 2 or 3 or 4 weeks of not doing any work rather than, 3 to 4 months. And that's kind of how I look at it. So I just say if we all just do our part and slow down, it'll be fine. And, the reality is the number of patients that still require our services is the exact same. It's not like it's going to change. The volume, if you look at the full year at a view, is probably going to be exactly the same. So we're going to have a few busier months down the road. Great. We'll all be ready to work a little bit harder. I think that's fine. I think the hospitals will accommodate that as well. So I just think there's the story to be told is like, I think to limit the impact even on us, financially, socially, et cetera, will be to, stick this thing out and not do elective cases. There's a second piece to that, by the way, Matt. One thing that's not being talked about much, I think there's a lot of this sense that, again, it's not going to affect me, especially in the surgical community, but I think we have to realize that the operating room may be the perfect petri dish for this virus, okay? Even taking, like, there was a report out of Wuhan where a asymptomatic infected patient infected 14 healthcare workers in their operating room visit. Because here's what happens. The patients go to sleep, you put a tube in there, there's secretions, it spews different places. Then they do this orthopedic operation where there's unfortunately, there can be some blood splattering, there can be, it gets kind of messy in orthopedics sometimes, even in spine sometimes, right? And what they're finding is that there's likely even transmission of the virus even in those settings because it's very opportunistic. Then take on top of that the masks that we typically wear in the operating room are not the recommended masks against COVID, right? So then on top of that, you have that kind of exposure. So you have aerosolized exposure. Then on top of that, the system of ventilation in the operating room is such that it keeps the air in the room. It's not, you're not allowing an exchange of airflow, right? And so now you're leaving the virus in the room for a longer concentrated period of time in general. And so it seems to be like even the operating room may be the perfect petri dish for people to get sick.
I think it's a really interesting insight and relevant, like you said, to a wide range of individuals, whether it be healthcare providers or certainly in the case of our industry, those on our team that are there as part of the continuum of care, whether it be our neurophysiologists or our representatives that are there as technical advisors. Greg, you mentioned a time frame to, we keep hearing this reference to bend the curve, right? To slow the rate of spread so we don't overwhelm the health system and ultimately begin to see a decline that allows a sort of a more normal cadence of elective or non-urgent procedures. And we're starting to hear, I think, similar thinking around what those timeframes could be over the next, let's call it 8 to 12 weeks. But even in that environment, it's highly unlikely that we're in a COVID-free environment. It's still there, and you touched on a couple of things, in your last comments that contribute to the potential spread. I mean, how should we be thinking collectively of environment over the next 8, 12 weeks that may be different than just a few weeks ago as it relates to how we provide care, patient selection, what is the environment going to be like in a hospital or health system that may have been different than what we've seen prior to now?
Yeah, I think there's going to be a definite transition into how we conduct ourselves in the operating room. And for instance, right now, Bob Eastlack is our division chief, and Steve Kopp is our department chair. And they're both reviewing cases even right now for cases that need to be done that are deemed urgent. So I think it's appropriate that there's sort of a sequence of getting at least 2 or 3 different guys on board with saying that there is appropriateness to the operation that needs to be performed. I think you're going to probably see something like that extend into the foreseeable future where we may do this by committee. At Scripps, we already have an indications conference, and it may be that we use that indications conference a little bit more towards like, okay, guys, what cases are we doing this week? Should we, are we okay as a group agreeing that we're moving forward with, elective spine in healthy or younger population, and then maybe delaying the deformity type operations, larger reconstructions to a time point when we're feel a lot safer in using those. Because the reality is, these deformity surgeries and bigger reconstructions will not infrequently require ventilator support after surgery. And to occupy the ventilator at this time, is not responsible. But certainly once we're past that inflection point on the curve, which will be different for every city, by the way, Matt. It's not going to be the same for us all. But once your own individual community has passed that inflection point, I think it's probably reasonable to reconsider these operations. But I would say it's nice if you have a review that you can go through to make sure that makes sense, right? Discectomies may be a no-brainer. That's no problem. But if someone that requires a hospital admission, particularly those that may require an ICU, those likely should be reviewed by a committee.
Greg, what about maybe even looking even further into the future? One of the things we've have often talked about and certainly seen play out in other segments of orthopedics and other subspecialties, but really the whole concept of shifting inside of care, and some of the things you're talking about are, taking patients that have other health issues or risk factors and exposing them into an environment where they may get sick due to something else. But there's also a concept of taking otherwise healthy people and putting them into an environment where they risk exposure to viruses or other pathogens that could make them ill. And some of the discussion being, hey, if there was a wider range of alternatives for appropriate patients, that was not the traditional inpatient setting, whether it be outpatient or ambulatory, that may be an advantage. Do you see or are you hearing anything that may suggest that there'll be broader conversations around how we manage site of care to potentially reduce the risk of exposure from viruses like COVID?
Yeah, I think it'll be, I agree. There's going to be a very interesting fallout from this. And my hope is certainly that it will be something that has a very positive effect on our ability to provide care. And you mentioned a very important one, which is, how do we establish ways of getting patients from requiring a hospital stay to not. And I think, or even, requiring a stay in a rehab facility or a nursing home, like those are certainly at high risk now. So, I think the health system hopefully will change in a very positive direction to make patients more independent earlier, allow them better functional status earlier, likely in their homes rather than in these acute care facilities versus long-term care facilities as well. And I don't know of any chatter out there yet, Matt, but if we have this conversation again in a year, I'd be really surprised if even Medicare isn't pushing harder for their elderly patients to be treated more on an outpatient basis. And it's certainly what's happened in the joint reconstructive field, where hips and knees are now almost routinely done on an outpatient setting. I think we're going to find ourselves in the spine community also seeing, decompressions and 1 and 2 level fusions from, head to toe. So, well, I guess it's not really toe, I guess, but head to sacrum being done in that same way. It just requires an infrastructure that has some support from the government, right? So Medicare has to support this. If they support the initiative, it'll happen.
Absolutely. And at least on our side, we hear some early stages of conversation around that. So appreciate your insight as well. Greg, I really want to thank you for your time. I know you've obviously got a lot going on, and it's a dynamic time for all of us, but for individuals like yourself and your family, obviously dealing with this in a very personal and firsthand way. We know there's a lot on your plate. So really thank you for taking the time, sharing your experience and sharing your insights. And per your response to the last question, we're gonna take you up on an opportunity to keep a dialogue going here and see not just how this plays out in the near term, but ultimately in long term, because I agree with you. There's I think an inevitability that we'll see an evolution of thinking and best practices as a result of a lot of what we're experiencing right now. So again, thank you very much, and best to you and your family. Greg, we'll keep thinking about you.
Appreciate all the thoughts and prayers, and I look forward to what's coming in the future. I think we're going to be positioned well to help our community, and I think this is ultimately definitely going to draw us closer together than further apart. So thanks, guys.